Hello everybody. Over the next 20 minutes we will talk about how digital health could be used to promote prostate cancer care. I'm looking at this from the radiological perspective. Here are my disclosures. So we all know that the prevalence of cancers is going up, and in the last 10 years we've seen the spend on cancer care increase by 4 times. And this is for men and women. And of course, in men, we are focusing today on prostate cancer, which you see here on the bottom right, which makes about 14% of all the cancers. So focusing on prostate cancer and what's going to happen over the next 20 years, what we see is an increasing mortality and an increasing incidence of prostate cancer. And we know that the mortality is mostly caused by the late diagnosis and the late treatment of high-risk disease presenting either with locally advanced disease or metastatic disease. Now, we have a number of challenges regarding prostate cancer that we all know about. One is the earlier detection of deadly disease and its treatment, at the same time not overdiagnosing and overtreating the highly prevalent indolent form of the cancer, which also exists. We know there are highly heterogeneous outcomes related to uncertainties. These uncertainties are related to the classification systems that we have, underlying genomics and molecular characteristics, and the variable therapy effectiveness of these techniques. We also know that there is an increased complexity of the care pathways. There are multiple transitory states. Sometimes you don't even see patients transitioning from one state to another because of the ineffectiveness of the diagnostic modalities. But we also know that as these transitory states come along, so the patient's priorities will change. And these are some of the states that I've laid out, with known cancer on the left, hormone sensitive and castration-resistant disease on your right-hand side. We also know that there's a rapid pace of knowledge, science, technology, and medicine, which means that we're moving away from the old paradigm, which was one size fits all, to the new paradigm of precision medicine. And of course, precision medicine is the right treatment for the right patient at the right time. And all the while we have to cope with the fact that we have limited healthcare resources, which is affecting both high income countries and low and middle income countries as well. So if we look at the situation in the UK, we can see on the left hand panel that the rate of prostate cancers in black men is much higher than in white men, but you'll notice that only 1 in 5 black men actually know that they are at elevated risk. If you look at the middle panel, you'll see that the prevalence of incurable cancers in London is 12%, and in Scotland it's 35% at presentation, so huge geographic variation. And if you look at the right-hand panel, you'll see that the life expectancy is very much dependent on your socio-economic status. And I've just taken that quotation from the right-hand side. The quotation says that people with lower socio-economic status spend nearly 2 decades less of their already shortened lives in good health. So they not only they live less long, but they actually live less well while they are alive. And this is the real problem. So all of these speak to the need to change the way that we think about prostate cancer. And this has now been incorporated into the NHS the NHS long-term plan. So the plan is a new service model of prevention, quality care, workforce, but centrally here you've got technology or digital. And what I've done on the right hand side is just highlighted a few things, but one of the things it says on the right hand side in the middle is that digital technology will facilitate service transformation, including the redesign of outpatient services and the reorganization of pathology and diagnostic imaging services. And this is, of course, where I come in. Now, we have to distinguish digitization, from digitalization, from digital transformation. So digitization is converting analog to electronic records. So, for example, paper requesting of examinations to electronic requesting as an example. Digitalization is what we produce. So, for example, scanner outputs, digital pathology, PAC systems, AI, robotics, that sort of stuff. But digital transformation is how you use digitalized data, people, and new processes to completely fundamentally change the model of healthcare delivery, which is what we need to do. And of course, this is the backbone of the digital transformation strategy of the NHS. We're not going to talk about this in any great detail. So what digital tools are available for patients? Well, one digital tool available for patients is to help them assess their own personal risk of having prostate cancer, depending on their age, their ethnicity, their family history. And I just wanted to show you a couple that are available on the web. You can see that these are multivariate tools that assess whether your risk is elevated based on your age, as I said, ethnicity, family history, and urinary symptoms. So this is a digital tool available for patients. So here in this modern prostate cancer pathway, we are talking about patients here on the left-hand side who are assessed clinically and with these new tools, which I showed you just in the previous slide. And those people with a higher risk undergo an MRI scan in today's environment. Now, of course, there are other tools that are available when patients already have cancer. So these are self-management tools that are also available. And here's an example. So here's here's an example of a mobile platform that enables patients to track, manage, and understand their own care. So you can see what the clinical benefits are. So it's possible to preempt and rapidly address any clinical deteriorations. It's possible to deliver cancer-specific information to the patients, and it is possible to use these sorts of tools to streamline follow-up services and reduce the burden of the workforce also. Now, in terms of digital tools that are available for professionals, healthcare professionals, of course, we are all aware of these: electronic records, wearable devices, telemedicine, clinical decision support tools. But one of these is, of course, imaging. And I've got that on the right-hand side. So imaging is not only scanners. We must remember that. It's not only scanners or PET tracers. It's quantitative imaging, it's radiomics, it's AI, it's new types of visualization, it's distribution networks. All of that comes under imaging. Now, we know that imaging can have a profound impact in terms of millions of deaths that are saved. So if we worldwide scaled up imaging, we would save about 2.5 million lives, and with a net benefit of economically of $1.2 trillion. If we scaled up imaging and care, in fact, you would save many more lives. You see, almost 10 million patients would be spared from dying, with an economic benefit that would be $2.7 trillion. So you can see the real impact that imaging could have. Now, previously, we've always focused on scanners and scanner technology, but really we have to try to reimagine the new transformation, not in terms of scanners, but in terms of next generation imaging. And next generation imaging is beyond scanners, beyond tracers, but it's about, as we said, quantitative imaging, radiomics, AI, new forms of visualization, distribution networks. So these new technologies enable us to reimagine prostate cancer by re-engineering the cancer pathways. And I just wanted to show you what you would need to do for imaging for it to become transformational in this way. So what are the engineering elements of this new paradigm? Well, this is covered in another video, and you can see the link up here for if you wanted to go and see a video on this area. But essentially what you need to do is you need to take these new generation tools, but put them into clinical trials for validating imaging biomarkers. You have to incorporate new therapy paradigms only after you deeply understand what are the clinical needs in each of these states and what next generation imaging technologies could do to try to improve matters. As I said, you'll be able to look at a more detailed video on this subject by pressing this link over here. Now, one of these tools is, of course, digitization or radiological digitization. So let's talk about another tool that's available for radiologists when they make diagnoses. So one tool is a tool that you could use after an MRI to decide which patient should have a biopsy depending on their risks and their preferences. So we're talking about a man who was assessing his own risk to get an MRI to somebody who's now had an MRI, and you'll see that we've now got an adjusted risk of the likelihood of cancer, but we still have to take into account his preferences. Now, if he is cancer averse, we would take a lower risk for a biopsy, but if he was biopsy averse, we would probably be more tolerant and have a higher risk before we biopsied him. So we need to take into account both urological and, of course, patient preferences. And we can do that by this type of digital tool. So here is a risk calculator that's again available on the web, which calculates the likelihood of cancer depending on the patient's clinical state, but also on the MRI. And I just wanted to illustrate that to you here. So here's a 47-year-old man, so young man, family history of prostate cancer, has a slightly raised PSA, but you can see his PSA density is actually normal at 0.049. Now we pass this data through an AI system, and the AI system says there's something here in the back of the prostate gland towards the apex, and you can see it in multiple images also, which is up here. But the AI says that the level of suspicion is actually very low. You can see it gives it a likelihood of 3, which means there's a low clinical likelihood that this is going to be clinically significant. Now I'm going to put that data into a digital tool and see what the likelihood of cancer is. So the tool that I tend to use is this tool, which is which matches the population of patients that I see. So I put his clinical details in here. You will see 47-year-old man, normal DRE, not Afro-American, has a family history. There's his PSA, has a large gland of 74 ml and an indeterminate prostate MRI scan report. And you'll see the risk of a positive biopsy is about 25%, but the risk of clinically significant disease is only 6%, so well below. So if you were going to biopsy him, you're more likely to get an insignificant cancer than a significant cancer. So this then can go on to an MDT, and the MDT decided, because there was a low risk, that there would be no immediate biopsy and that he would undergo a safety net of follow-up. So you can see how we've used the imaging and the clinical metadata to try to triage a biopsy in this particular individual. Now, if we were to use this sort of tool in this kind of patients, and we used, say, a threshold of 15% before we undertook a biopsy, you'll see that you avoid about 36% of biopsies, and you end up with far fewer biopsies that don't have clinically significant cancers. So if you biopsied everybody, 70% of the biopsies that you performed would be unproductive, in other words, wouldn't have clinically significant cancers. And that goes down to 50% at the cost of about 8% of clinically significant cancers being missed. So you can see how we can then translate this into a benefit where we can forecast how many biopsies would be avoided, how many biopsies we could, how many fewer unproductive biopsies we would have. Now, to put this all together, we are going to need automation. And you can now begin to see AI being used increasingly to automate radiological practices. So one of the areas that we're seeing AI being introduced is in the clinical workflow to acquire the data. And I just wanted to show you an example of that. So what you see on the left-hand panel is a man who has prostate cancer. And we can see that he's got metastatic disease, all those dark spots. And the left-hand panel is the conventional sequence. And in the right-hand panel, which is this panel here, is the AI acquired panel. And what you notice is that the conventional imaging, this was 14 minutes. This is 6.25 minutes. So in other words, the AI gives you, in fact, improved diagnostic quality at less than half the time that it would have taken to scan this man in a conventional way. So this is a way of you seeing how AI can help accelerate the acquisition of the data for analysis. And in fact, when we looked at this in a systematic fashion, what we found was that the overall artifacts on lateral views and in frontal views was in fact markedly reduced using AI. The lesion conspicuity was about half and half. So in other words, in about half the patients, the lesions were better seen. And this, you can illustrate this over here in this man. Looking at him, you can see these lesions are much better seen with the AI acquisition rather than in the conventional acquisition. And part of that is related to the much more even suppression of the background fat, which you can see is much better suppressed. Now, of course, we need to go beyond just acquisition to image analysis. And we are now seeing how we can automate that acquisition with an image analysis tool in a seamless pipeline. And the AI can then be used to analyze these images to say, there's a cancer, that's what needs to get biopsied. So we are developing a pipeline of AI and digital tools that will yield an actionable result on the need for biopsy. So what can we say about what a radiologist will do in the future? He will clearly take the data that's been pre-processed and acquired. He will use the AI, but his reports will then take into account and integrate into the clinical metadata. In other words, the future radiologist will not only be looking at images, he will look at clinical information, including the blood work. He will use advanced visualization and AI to deliver what are called actionable reports. And the AI will help decide who to look at first. So this is shown, I think, quite nicely in this illustration. So you can see this particular AI looks at the scans even before the radiologist looks at it. This particular AI has looked at all the images, it has processed the images, and it's given scores for the overall likelihood of clinically significant cancers here, and the number of lesions that are there, and where it found nothing at all. So you can see how that this AI is already beginning to triage patients to say, this is the person you should look at first, and maybe look at these later on. So this is how the AI is helping the radiologist triage his patients in a better way. Of course, the important thing to do is at the end is to have that an actionable output. In other words, the result should improve the efficiency of the biopsy or the treatment decisions. And so we're talking about moving into this last space where the diagnosis moves into a biopsy decision. And I just wanted to illustrate that to you very quickly. So here's a 58-year-old man with a family history of prostate cancer carrying a BRCA mutation. This small tumor here is actually quite difficult to see on the morphological imaging. It is visible here and here to the expert eye, but the AI clearly points out that there is a lesion here that needs to be biopsied in a patient with a strong family history, and in fact gives a suspicion score of 90, in other words, highly likely to be a clinically significant cancer. Now, of course, we need the action to be a biopsy, but by pressing this button here, what happens is we get an actionable result. So the actionable result is this prostate outline here with the transition zone, the peripheral zone, and the tumor here, all outlined, and it goes directly into the biopsy device for an appropriate targeting biopsy of that lesion to be done. So you can see how this process can become much more streamlined from suspicion all the way to a biopsy. Now, we need to improve the efficiency of multidisciplinary care, and this was shown here quite nicely in this recent paper. So in this paper, they took men who were diagnosed to have prostate cancer, and then they were able to make much quicker decisions regarding the appropriate treatment for that particular patient. So a theoretical patient here, you can see that he has a Gleason 7, PSA of 6.9. He has a good performance status. This is where the radiologist said the tumor was. These are the biopsy cores here, and you can see that on this side a surgical procedure was recommended. So a much more streamlined approach as to what should happen in this particular instance regarding therapy for this particular patient. Now, so if we step back now and talk about the benefits and the limitations of digitalization. So we can say that digitalization will enhance diagnostic accuracy. It'll enhance collaborations, particularly in the MDT. We will be able to give patient-centric care, in other words, a personalized treatment, so the right treatment for the right patient at the right time. But there are going to be limitations. These limitations are the implementation costs. The costs are likely to be massive. There are, of course, data privacy and security concerns, particularly when you have external players entering into this space. There will be a training requirement to work differently, and healthcare professionals can sometimes be reluctant to change what they do. And of course, there will be technical challenges when we start introducing these new technologies of telemedicine and AI into our practices. So if we just now step back and say, okay, of the challenges that we identified at the beginning, what AI tools have we got? What digital tools have we got that can address each of these? Well, in fact, it turns out we have quite a few of the tools. So, for example, for the early detection of deadly disease, we've already talked about this. We have risk calculators. For the heterogeneous outcomes related to diagnostic uncertainties, we have predictive models that take into account not only imaging, but liquid biopsies, genomic profiling, proteomics, and clinical factors. The increasing complexity of the patient care pathway, well, we have digital care solutions, we have electronic healthcare records, and the cancer digital playbook to be able to use the right treatment for the right patient. And we talked about having an explosion in the amount of data and data science and how we cope with all that. And of course, telemedicine, literature synthesis, clinical decision support tools, health information exchanges will all be important. And of course, a lot of these will then feed into decreasing the load of the pressures that we have in healthcare resources. So this is my final summary. There's no doubt that digital transformation will improve the efficiency and the accuracy of the prostate cancer pathways. No doubt about it. Digital technologies will help healthcare professionals provide a more personalized care to their patients. Digital healthcare technologies will help healthcare patients and support them through their treatment and their survivorship. And in fact, if we think about it, these digital healthcare technologies have the potential to impact millions of men all over the world, helping them to live longer and better lives. I hope you found some of these comments useful as you think about your own digital health transition. Thank you very much for listening.